I had a couple questions. One of them was, what is your PhD in?
My PhD is in tumor cell biology. I actually did my thesis on um, basically Epstein-Barr virus and how it transforms into a cancer process. So looking at the signaling mechanisms that a lot of our drugs now use to treat cancer.
Wow, Epstein-Barr is very interesting what it does.
Yes, it is.
I mean, but really you wrote a dissertation on that. That's pretty. So all the signaling messages and how they, kind of take over the metabolism kind of stuff.
Really looking at the cellular receptors on the actual B cells to show how the virus changes the B cell morphology and the protein receptors on there to transform it into cancer.
Wow, wow. And were you studying a specific cancer like gastric
Pretty much
lymphoma?
lymphoma. Mhm.
Okay, all right, that's what I wondered. Yes, Dr. Rachel Swart has agreed to talk to us. She's a oncologist that specializes in breast disease. And I think it'll be an interesting discussion because of the prevalence of breast cancer and the amount of information that's so difficult to sort through. Having an expert to be able to kind of help guide what's going on. I guess the first question I would ask is, you must have to use a team approach to what you're doing. I mean, there's a lot of moving parts in breast cancer. There's surgeons and reconstructive and radiation. And so does your office, or do you tend to be the CEO of the ship and try to help people manage their way through the treacherous waters?
So, as a medical oncologist, we do work with a variety of other specialties when it comes to treating breast cancer. We have our breast surgeons, we have our radiation oncologists, our plastic surgeons, and then myself, who does end up being mainly the point person. But also in our office, we have a breast cancer navigator who really helps to make sure that a patient gets to all of our subspecialties in a timely fashion, as well as making sure they're getting their imaging and their biopsies on time.
Well, that must be very helpful, knowing
Yes.
that someone has someone there supporting them and being able to help them in what they're doing.
Mhm. It is
Excellent.
very much so. It's a very complicated process, but the team approach is always the best approach because you need to have all the different subspecialties there to make sure that they're giving the appropriate care in a timely fashion for our breast cancer patients.
So you're not directly involved in women getting mammograms, more they're coming to you with a diagnosis. Do you, you know, I think sometimes maybe you could explain a little bit. I don't know whether women necessarily understand the difference between a screening mammogram and a diagnostic mammogram and an
Mhm.
MRI. It's kind of sometimes it needs to be stepwise in terms of how people do it.
That is correct. So, most patients should be getting a screening mammogram, and the US Preventative Task Force actually changed the criteria back to the original 40 years older yearly screening mammograms, which we recommend. And they are getting a screening mammogram that is still a 3D modality. So, we only use 3D mammograms now. It gives us a better picture, less radiation to the patient than the previous mammograms we used to use. And so once you have that screening mammogram, they're able to find any sort of abnormality which may be detected. And if there is one, then the radiation or radiology company will call the patient back in and say, we need to have now a diagnostic mammogram to be able to take a look and say, okay, is there something truly there that may be non harmful, or is there something there that needs a biopsy? And then once a biopsy needs to be done, then they bring the patient back. They usually will get a ultrasound guided biopsy, or sometimes less frequently there will be a stereotactic guided biopsy if there are only calcifications seen. We don't tend to do a lot of excisional biopsies anymore because the core biopsies are so good now.
Okay, that's understandable. So how do you see the direction that you help people with when it's time for them to get chemotherapy? I assume that you have to have a period of times where you talk to them about what the biopsy's shown and the aggressiveness. And I assume that is what influences you. And do you follow specific standards in terms of a protocol from a certain center, or is it an individually personalized kind of treatment that you work on usually?
So a lot of times the patient will come in and either first see a surgeon or sometimes they'll first see a medical oncologist. A lot of it depends on the type or the subtype of breast cancer that you've been diagnosed with. Most of the time, the standard way that most patients will come in for treatment of their breast cancer will be a surgeon first, going to surgery, then proceeding to seeing a medical oncologist. After that, seeing a radiation oncologist, and either chemotherapy will be given before radiation or radiation will be given, and maybe they just need to be on a pill, what we call hormonal therapy or anti-estrogen therapy after radiation. And all of these steps depend on the subtype of breast cancer and the amount of cancer that the patient has at the time of initial presentation. So for me, really I need the patient to come in with a biopsy result, know the type of cancer that they have, and then based on the amount of cancer that they have, we sometimes do the breast MRI to determine a more exact size of the cancer, determine really if there's any lymph nodes involved under the armpits on the side of the cancer. And then once we have that information, the patient may need further imaging with maybe a CT scan, a bone scan, or possibly a PET scan to provide us the staging. These types of images we tend to do if the patient is found to already have lymph node positive involvement of their breast cancer.
Okay.
And then from there, then we can figure out what our standard treatments are going to be based on all of that information.
So do you find that you're seeing more and more women now that are coming in at earlier stages and are able to get hormone-based therapy rather than chemotherapy?
It's very interesting because it can be very different. What I see right now is I'm seeing more younger patients, women who are premenopausal, whereas before we would see a lot more postmenopausal women.
Yeah.
As you hit over the age of 65, and in that postmenopausal range, your risk of having invasive breast cancer goes up. So the fact that we're seeing it more in premenopausal women can be due to a variety of different reasons, but they also tend to have more disease present than their postmenopausal counterparts. So a lot of women will need to have chemotherapy or some treatment before they go to surgery if they have a larger cancer, if they have lymph node involvement, or if they have specific subtypes of breast cancer called either HER2 positive breast cancer or triple negative breast cancer.
Okay. So are you saying that getting chemotherapy before surgery implies that these are more aggressive cancers in these younger people?
They can be more aggressive cancers, particularly in our younger patients. But what we have found from our more recent studies is that treating these more aggressive cancers up front with chemotherapy provides a better outcome in the end, where they're less likely to have recurrence of their cancer for the remainder of their life.
Oh, okay. Well, that's probably something people would choose to do, to go at the front end. I think it's very interesting, menopausal women primarily getting hormone therapy, hopefully, in a lot of cases. I was looking at that. It's amazing to think that like estrogen blockers and HER2 blockers, they've only been around for 40 or 45 years. It's not something that's been a common thing that's gone on for since the 50s or the 60s. It really took a long time for that research to develop and show how effective it was. Do you think that was because it was difficult to find the receptors, or was it difficult to get the studies to show that they worked?
Probably a combination of both. So we only had initially back in the 80s really testing the estrogen receptor positivity and the progesterone receptor positivity on a breast cancer. HER2 came about later on, and then being able to actually target the HER2 protein that's on breast cancer cells, that took quite a while before we actually got HER2 targeted therapy that was actually FDA approved. And that happened back in the 2000s.
Oh, okay. All right. So do you have specific aspects? I imagine you're seeing a large number of women that are having sometimes deforming surgery, but breast cancer brings up a lot of emotional aspects for a lot of women. Do you find that you spend a great deal of time talking to them about the impact and what's going to happen, or do you have people in your office that tend to do that?
So our office does have our breast cancer navigator as well as our social worker that does put a lot of our patients in contact with maybe a counselor or um, breast cancer groups, both
Mhm.
social as well as support groups, to make sure that they have someone helping them both mentally. Because we talk a lot about the physical aspects of breast cancer, what the chemotherapy is going to do, surgery, how to recover from those things. But I always tell my patients that 50% of your journey through your breast cancer diagnosis is going to be the mental aspect of it. And for most breast cancer patients, a lot of them are just going through the motions of doing treatment. And then maybe a year or even 2 years later, the emotional aspects of having been diagnosed with breast cancer and being a survivor then start to take effect. And so it's a long process that we go through with our breast cancer patients. And I personally, want to go through that entire process with my patients because I understand it since I'm currently a survivor myself.
So you were in breast oncology before you had breast cancer?
Yes, I was diagnosed with breast cancer 4 years ago and have gone through the process myself and still on anti-estrogen therapy.
Okay.
So I have a lot of empathy for my own patients
Yeah,
as they go through this process, and it can be very challenging.
I bet it can. Do you find that the anti-estrogen therapies are fairly easy for women to take with, there are side effects possible, but I assume you don't see a large percentage of people really having problems taking them, or do you?
Well, there are some women, approximately 7 to 10% of women, who cannot tolerate any of our anti-estrogen therapies. The quality of life, the side effect profile of them is just, it's not possible to live while trying to take these medications. But a majority of women are able to actually get through their 5 or 10 years of anti-estrogen therapy, which is dependent upon their cancer type as well as the aggressiveness of their cancer, which we have very specific testing now that we do on tumors to tell us who needs 5 years versus 10 years of anti-estrogen therapy. Majority of the time, it is really listening to the patient and making sure that you're addressing the menopausal symptoms that are causing the quality of life issues. Because if you can help to manage those menopausal symptoms, I personally find that my patients are able to get through their anti estrogen therapy, whether it's changing the medication, whether it's using maybe a prescription or maybe a natural way to actually offset some of those menopausal symptoms. We have a full list of information of different supplements as well as integrative therapies such as acupuncture that have been very helpful in managing menopausal symptoms as you're on anti-estrogen therapy. And I think the best thing that a patient on anti-estrogen therapy can do is really sit down and have that discussion with their medical oncologist as to what can I do safely? What would you be recommending? What alternatives do I have to helping me through this 5 to 10 year process on anti-estrogen therapy so that you can get that benefit? Because with estrogen positive breast cancer, when we put women on anti-estrogen therapy, we are lowering their risk of recurrence of their breast cancer elsewhere in their body by 50%. And that's a huge benefit to our patients.
Probably the highest percentage you can get for most cancers.
That is correct.
So talk a little bit about also, you kind of made a little discussion there about genetics. It's not, if I remember correctly, you are now very involved in the genetic testing, and maybe you could talk a little about what that does and why you do it.
Well, the genetic testing is really to make sure that an individual that's coming in that has been diagnosed with breast cancer doesn't have a genetic mutation in their family that puts them at risk for having not only another breast cancer, but maybe at risk for other types of cancers. So when someone comes into the office and I take a look at their family history, if they have a history of multiple family members with breast cancer, a family member with melanoma, pancreatic cancer, prostate cancer, we're going to say that these are the cancers that can be associated with those particular types of mutations, and thus they fit our national guideline criteria for getting genetic testing. We like to get the genetic testing before surgery because if someone has a genetic mutation that increases their lifetime risk, like let's say a BRCA mutation, a BRCA mutation, that may increase your lifetime risk by 60 to 80%, then we're going to talk to patients about removal of both breasts to prevent a second primary breast cancer. And so to do that before the patient goes to surgery for the cancer they're now diagnosed with makes it easy so they're only having one surgery. And then we talk to them about, okay, what other cancers may you be at higher risk for? And how do we follow those cancers and make sure that we're monitoring for them appropriately?
You're talking about something like Lynch syndrome or
Lynch syndrome, or if you have a BRCA2 mutation, you're at risk for both melanoma, you're at risk for pancreatic cancer if there's a family history already of pancreatic cancer. Any male in your family that has a BRCA2 mutation can be at risk of prostate cancer. So it's not only protecting the patient that has already been diagnosed with cancer, it's also making sure that that patient realizes the importance of telling other family members that they may also need to be tested to make sure they're not at risk for these cancers. But I will say, most of our patients don't have any genetic mutation associated with their breast cancer. We really only see genetic mutations in less than 10% of our breast cancer population.
do you feel that some of the more integrative concepts now of xenoestrogens are playing a role in women that are developing breast cancer?
There's a variety of different theories out there as to why younger women particularly are developing breast cancer. And that is one of them. Our environment always plays a role in how it affects our health and our bodies. And of course, anything that's estrogen producing or exposes us to more estrogen obviously can have some increased risk. That goes all the way back to whether or not you go through a full-term pregnancy. It goes back to if you have hormone replacement therapy, if you're postmenopausal. anything that provides that additional estrogen may always lead to somewhat of a higher risk.
So obviously there's a lot of things that people can be doing, and obviously watching what they're eating in their diets. And it sounds like you really feel that having mammograms earlier now is going to be an important diagnostic tool to be able to find women earlier who might not recognize. They probably think, oh, I'm only in my late 30s or early 40s. I don't have to worry about this for a while. But you're saying that doesn't seem to be the case anymore.
Not necessarily, it does not. And so that's why women knowing their risk. So not only are younger women making sure that they get their diagnostic mammograms starting at age 40, but also if you have a family history, really you should be having breast examinations done by your medical provider on a yearly basis, sometimes starting as early as 30, depending on the family history. And then also, we don't necessarily have a cutoff for age for mammograms. If a woman is in her 70s or 80s and is healthy enough to undergo a simple surgery, those women should also continue to do yearly mammograms so that we catch a breast cancer early so that we can intervene at an early stage.
Well, that makes a lot
And
of sense.
then, yeah, and then also knowing what other risk factors you have for breast cancer. So, making sure that uh, you're not in the overweight or obese category. We know that obesity does contribute to a lot of our cancers. Exercise is very important. That also helps to reduce your risk of cancer. Knowing your family history is very helpful. And then also stress. Stress in our lives can actually increase our risk of cancer. And those types of studies are now slowly coming out. Not only that it's beneficial to decrease our risk of having a cancer, but also beneficial for our survivors out there from breast cancer, that they decrease their stress to reduce their risk of recurrence.
Well, it also appears that the literature is showing that after being treated for breast cancer, that maintaining a healthier weight and trying to do more physical activity can reduce the risk of recurrence. So lifestyle is important. And it sounds like since you follow these people for long periods, you have the advantage of focusing more on their lifestyle according to what risk they have for recurrence of their breast cancer.
Yes, that's part of our survivorship follow-up that we do. So that program encompasses, once we get patients to a point where they feel like they've been able to both physically and emotionally recover from their initial diagnosis of breast cancer, we start sitting down and talking to patients about, how do I prevent having this come back? What else can I do in my lifestyle to reduce that risk, such as regular exercise, eating right, making sure you're getting plenty of sleep, and lowering that stress level. And so we're constantly having those discussions with our patients as we see them in their follow-up, not only to check and see if they have recurrence of their cancer, but that's also part of the whole health process, is making sure that they're taking care of their bodies and their mental health so that we reduce the risk not only of additional breast cancer, but also of other medical issues in the future.
Well, it certainly sounds like in this age of less time that you're willing to put in that extra time to make sure that it's not just a quick visit and how are you feeling? It sounds like there's some real issues that need to be reinforced and addressed with each visit.
That is correct. We feel very strongly in making sure that we're treating not only the body, but also the mental aspects of a patient, because those need to be in balance in order to make sure that we stay healthy in the future.
So do you see the future of breast cancer being more along the lines of earlier diagnosis and better ways of finding it before it becomes a problem? Or do you think that the newer chemotherapies are going to add a lot to your armamentarium of treatment?
Well, I think we're not going to be able to find every single thing that would be able to cause cancer in a human being to prevent that. There's a lot of things that we can do, but sometimes I tell my patients who feel that they've done everything right, and I've treated patients who are athletes, vegans, sports fanatics, you name it, have done all the correct things, but still end up with cancer. And when we talk about how they got breast cancer, sometimes I have to say that cancer really doesn't distinguish. It really doesn't care if you've eaten right your entire life sometimes. It doesn't care if you've been the healthiest person you've ever been in your life and exercised every day. Sometimes it just decides that you're it. And we have to then be able to address that issue, get you the treatment that you need so that you can go on with the rest of your life. And I do feel that where we're looking at all of these new targeted therapies, and at Arizona Oncology, we have multiple clinical trials that we are running for our breast cancer patients so that we can bring a lot of those new targeted therapies into the forefront before people become stage 4 or have metastatic breast cancer, so that we can actually make sure that we give our patients the best chance of never seeing their breast cancer again. And I think it's going to be those targeted therapies is really where we're going to change how not only breast cancer is treated, but all of our cancers are treated in the future.
Well, it does appear that cancer is, it's certainly divided now into specific organ systems, but it sounds like in a lot of ways, a lot of cancer is starting to become, what receptors do you have? What are you going to respond to? So you could have cancers in different organ systems and still get the same chemotherapy because the markers are, we're recognizing as being kind of more present for a lot of different cancers, it appears. Do you see that that's happening also?
Yeah, a perfect example is the medication or the targeted therapy Herceptin, which was the first one to be developed for HER2 positive breast cancer back in the early 2000s. It became FDA approved. And now that particular drug is being used for gastric cancer. It's being used in colon cancer. As long as those cancers have that HER2 marker, that drug has now transitioned into different cancers, and patients have had excellent response. Same thing goes for other cancers with targeted therapy. If we find that target in breast cancer, we're trying to use those drugs for our stage 4 breast cancer patients so that we can get their cancers under control and give them longer lives to live and a better quality of life.
Well, it sounds like with breast cancer being probably the number one cancer in women, having a dedicated specialist that's able to just deal with that issue kind of really gets the focus there, rather than some of the general oncologists that deal with a variety of different organs. It must take a lot of time to be able to keep up with what's going on in your field alone, just in terms of what's available for patients.
It is. It's become very challenging. I mean, just last year alone, they must have approved about 50 new drugs in cancer. And so, yeah, cancer, that's a lot of drugs to know as a general oncologist. And so it's very difficult sometimes to keep up with all of the cancers. That's why there's a lot of us that are specializing in different areas to make sure that we are staying up to date as to the most recent clinical trials, any new drugs available. And then that way you can bring a lot of speciality to the patient so that they know that they're getting the best that they can out there. I will say, though, is that, I tell my patients when they come in, even though I am a breast cancer specialist and I've been doing this for close to 20 years, I tell them that they should never hesitate to get a second opinion. They should never hesitate to find the oncology team that they're going to feel most comfortable with. Because this is a long-term relationship with our patients that we have. And the patient needs to feel comfortable with the medical oncologist and their team. They need to feel like they can have conversations regarding side effects or quality of life issues they're having with their treatment. And so that's very important. And I tell all of my patients that they need to be their advocate for their healthcare.
I think that makes it a partnership rather than necessarily, I mean, it can't just be the doctor telling you what to do anymore. It sounds like you can explain what's going on, and if you have that relationship, you can have confidence in your practitioner that they're doing the right thing for you, as opposed to, this is just how we do it. And it sounds like you have a lot of different available tricks that you can use, different therapies if one thing is not available. I assume there's also, how much it costs and can you get insurance to cover it? So you have a lot of logistics you have to cover, along with, you have all the physical aspects and then the emotional aspects, and then even getting them treated can sometimes be difficult to deal with a company that doesn't want to pay to have what you feel is the appropriate drug to be used.
Well, I'd have to say that used to be, I think, a little bit more challenging than it is nowadays. There's a lot of support out there, particularly for breast cancer patients, with a lot of our oral medications, both with outside organizations providing funding to breast cancer patients, but also our pharmaceutical companies being able to provide assistance with some of our more expensive medications so that our patients can get treated when they need to have that medication.
It's good to know. I think some women have a fear that they're going to not be able to afford what they need because it's too expensive to pay out of pocket, but that's a good thing to know. Are there any concluding remarks that you would like to pass along that you feel would be important in terms of how you approach things?
I would just tell someone out there who's having to deal with breast cancer is that can be a challenge. It is a journey. It's a journey that I think you need to look for the best providers that you feel comfortable with in your journey. That you need to look at both the physical and the emotional aspects of dealing with breast cancer. And that with a lot of our new treatments that are out there, breast cancer is a very treatable cancer. It is also a cancer that even in the metastatic setting, we're now talking to patients about living years. It's not necessarily something that is an imminent death sentence that a lot of people used to think it was. And so therefore, to really be able to find the place and the doctors and the support that you're going to need to get through this journey, because there is a light at the end of the tunnel and you will be able to go on and enjoy your life. And I wish that for all of my breast cancer patients.
Well, thank you. That's great. It sounds like, breast cancer is coming into the category of being a chronic disease rather than something like you said, like people used to think that if you had stage 4 breast cancer, you didn't have long to live. And you're kind of saying that isn't the case anymore. We're able to give you a quality of life that can allow you to continue and thrive.
That is correct.
Well, good. Well, thank you very much. Thanks for the time. I really appreciate you being able to hopefully explain to people some of the basics that they need and how important it is. And just to hear you say that you're not the only one out there that can do this, and that it's really about how does that fit come about, and encouraging people to find the right situation. I think that says a lot about, you wanting to do the best you can, and to have that same kind of situation where you feel comfortable and so does the patient. So that makes a much more ideal situation. Well, thank you for your time. And
you're very welcome, Dr. Levy. Thank you for inviting me. I appreciate it.